Shall I start your 2 minutes time? Soumya?
Yes, ma'am. Yes, ma'am. Yes, ma'am. Ready, ma'am.
I'm starting, okay?
Okay, ma'am.
Second, another slide, okay? 2 slides only.
Okay. Okay, ma'am. Next slide, ma'am.
These are props actually.
Okay.
Starting your 10 minutes time.
Okay, ma'am. Hello, I'm Soumya. I'm ST5, and you are?
Hi, I'm Prajakta, the ST1 new trainee just joined.
Nice to meet you, Prajakta. So, how is everything going in the department, and how is your training going on?
Yes, the things are pretty at its respective places, and my training is also going very smooth. Recently, I have conducted a vaginal delivery. Now, I'm really keen to know about instrumental delivery, especially vacuum delivery.
That's nice to hear. It's very good to know that you are interested in the instrumental delivery. So, before that, I would like to ask you: have you seen a instrumental delivery being conducted before, or have you read about that prior?
Yes, I have
Okay,
seen
so
few deliveries which was
oh,
going on, but still I would like to know in detail about the instrumental, especially vacuum delivery.
okay. Okay, Prajakta. So we will discuss everything in detail today. So first, I will tell you about the indications for instrumental delivery, then prerequisite, preparation of the mother, then application of the vacuum, and then we will discuss about the complications. So how does that sound to you?
Oh, yeah, that sounds great to me.
Okay. Is there any other thing you want me to discuss?
No, I just wanted to, I'm keen to learn this on mannequin and I hope you will give me a hands-on.
Surely, we will demonstrate it on a mannequin also. So before that, I will give an overview about the instrumental delivery. Then we will proceed with the mannequin. Okay.
Yeah, that will be great.
Okay. So first, coming to the indications of instrumental delivery, are you aware of the indications?
No.
Okay, so no worries. It can be divided into a maternal indications and fetal indications. Fetal indications, as such, means suspected fetal compromise in second stage of labor, like a pathological CTG. Uh, Coming to maternal indications, it can be due to the prolonged second stage of labor. That means in primary gravid patients, usually it is more than 3 hours with in patients with epidural analgesia, or if it is more than 2 hours of second stage of labor without epidural analgesia. But in multi paras patients, it can be more than 2 hours in case with epidural analgesia and more than 1 hour without epidural analgesia. Got it?
Yeah, that's great. Thank you.
Oh,
Yes, got it.
okay. Then we can apply forceps as a prophylactically in certain maternal medical conditions. So that women can avoid the pushing during the second stage of labor, like cardiac disease patients with an IHA classic functional status 3 and 4. Then hypertensive crisis, if the patient has myasthenia gravis or some spinal cord abnormality.
Mm.
Also, in lastly, in a proliferative retinopathy. Okay, in these patients, we can apply prophylactically during second stage of labor to avoid the maternal pushing. Okay.
Yeah.
Lastly, in case of maternal exhaustion, also we can apply for instrumental delivery. So,
Hmm.
am I clear about the indications?
Yeah, quite clear.
Okay. So then, coming to the prerequisite of instrumental delivery, so we have to ensure proper upper abdomen and the vaginal examination. In per abdomen examination, the head should be less than one-fifth palpable per abdomen. In
Hmm.
vaginal examination, the cervix should be fully dilated and the membrane should have been ruptured. And we should know
Hmm.
exact position of the fetal head so that we can know a proper placement of the instrument. Okay.
Okay, got it.
Also, and the pelvis should be adequate, and we have to make sure an adequate analgesia is available, and
Okay.
we have to empty the bladder prior to applying the instrument.
Okay.
Okay. Also, we have to assess for caput and molding present. If there is a irreducible molding present, then it can indicate a cephalopelvic disproportion. So we have to examine thoroughly before performing an instrument delivery. Got it?
Yes.
Any doubts so far?
No, doc. No, no, no,
Oh,
Soumya.
okay. So coming to the preparation of the mother, we have to communicate to the patient. So what exactly is going on and what are we going to do? And we have to get a consent from the patient. If you are going to apply instrument in a labor ward, we can get a verbal consent. But if we are going to apply it in an operation theater, then we have to get a written consent from the patient. Okay.
Oh,
If the
yeah.
patient uh, if the patient is
Yes.
already on epidural, we can continue with the epidural analgesia. If the patient is not on epidural, we can give a pudendal block also. Okay.
Okay. Yes, got it.
Okay. Got it. So then we have to ensure the correct position of the patient. Patient should be put in a lithotomy position, and we have to bring her to the edge of the table. And we have to empty the bladder before performing the procedure, and we have to make sure the adequate analgesia is in place, like already I discussed.
Yeah, you had
Okay.
already told
Already
this.
discussed. Yes. Then we have to clean and drape the patient.
Hmm.
So coming, I will discuss about the steps of the vacuum delivery. Then we will go on to mannequin.
So
Okay.
here, yeah. So here it is a mannequin. Can you just demonstrate the steps on this mannequin?
Yeah, sure. Okay. So first, this is a vacuum cup. We have to choose the correct vacuum cup according to the baby's fetal head. Okay. Then we have to ensure that the pressure pump is working and everything, the machine is ready properly. Okay.
Yes, yes.
Then we have to again perform the procedure, again do the examination to confirm the baby's correct position. Then
Hmm. You had discussed all these things. Now the
yes, yes.
procedure actually.
Yeah, we have to first apply the cup to the baby's flexion point, that is 3 centimeter in front of the posterior fontanelle. That is a flexion
Hmm.
point. We have to apply
Hmm.
the cup over the flexion point, and we have to connect it to the suction apparatus. We have to ensure that the no maternal parts is catched upon between the vacuum cup and the fetal head.
Okay.
Then first we have to raise the pressure initially to 2.2 kg per meter square. Then again we have to ensure that no metal part is stuck between. Then we can increase it to 0.8 kg per meter square pressure.
Okay.
Okay. Then we have to wait for the contraction. So with
Hmm.
contraction, ask the woman to push. Also, we have to apply the pull in the direction of the maternal pelvis. That is according to the position. So if the baby's head is in the outlet, just an extension movement is enough to deliver the baby head out. But if the baby's head is slightly above, that is in the near in +2 station, we have to apply the traction in downwards and forward direction initially, then downwards and backward direction. Okay.
Okay. Yeah, yeah.
So once
Got
the
it.
once the fetal head is crowned, we have to evaluate the mother for need for episiotomy. If episiotomy is needed, we can give one and deliver the fetal head, followed by the body as usual in the second stage of labor in any other case.
Okay.
Okay. So after delivery, we have to evaluate for episiotomy tears as well as a cervix to evaluate for any other tears. And we have to estimate the blood loss.
Hmm.
Also, we have to take a paired cord blood sample to document pH and the lactate in any case of instrumental delivery.
Okay. Okay. Got it.
Okay, okay. So now, do you want to practice in a mannequin now?
Yeah, I will be very happy to practice it.
Okay. So after all this procedure, we have to debrief the woman about the procedure we have done, and we have to
Mhm.
document it properly for as it is an medical legal document. We have to document it properly. Okay.
Okay. Yes.
Yeah, okay. So coming to the complications of vacuum delivery. So in a
Hmm.
coming to maternal complications, it can be increased risk of postpartum hemorrhage, and the tear can be extended. Episiotomy wound can be extended. We can get a third degree or fourth degree perineal tear, and
Okay.
urinary problems in immediate postpartum period. We can get an acute retention of urine due to the injuries to the bladder, nerve injuries to the bladder. So in
Hmm.
coming to the fetal complications, we can get minor complications like cephal hematoma. Sometimes it can usually it will resolve
Time up.
within a.
Time up. I'm giving you extra 1 minute. Okay.
Yes, ma'am. um, the cephal hematoma usually it resolves within a week after delivery, or sometimes there can be a serious complications like intracerebral hemorrhage or a jaundice, neonatal jaundice, etc. Um,
Okay.
okay. So
Yeah.
so do
It's
you,
a quite clear. Quite clear. I got quite clear picture.
okay. So how do you think the session went?
The session went well. Actually, I came to know
Mm.
about too much practical and theoretical knowledge of Kiwi Force. So
Okay. I will give you learning resources from RCOG and strat videos also to help you learn better. And then if I come across any other case, I will definitely call you in future.
oh yeah, that will be very great. Thank you.
Thank you.
Thank you, dear.
Thank you, ma'am.
Yeah, completed. So this 1 minute you have to save, dear. Okay.
Okay,
Where
ma'am.
do you think you could have saved it? This is my
I am
observation.
repeating again and
No,
again the
twice or thrice only
examination
you
findings.
twice
Yes,
or
ma'am.
thrice only you repeated that to bladder analgesia and per vaginal examination where I rushed
Yes,
you. Okay.
okay,
So
ma'am.
that is not an issue. Indication, dear. Indication, no
Oh,
need of going in so much of indication detail.
okay, ma'am.
Maternal indication, fetal indication, combined indication, and a maternal indication. You just need to tell her second stage arrest in multi or primary.
Okay, ma'am.
See, it is actually not you. They are not testing your knowledge here.
Yes, ma'am.
Okay, and then Valsalva maneuver, wherever Valsalva maneuver is contraindicated in those cases, heart
Yes,
disease,
ma'am.
one or two things is sufficient enough. That means you
Um,
know that there are this indication.
okay, ma'am.
So going in that detail, you took almost 3 minutes, completed 3 minutes by that time.
Okay,
So
ma'am.
good that you are having a very good knowledge. And here in part three, nobody is going to test your knowledge. They just
Yes,
want
ma'am.
to see your approach, what approach you are following, whether you are following a correct approach or not.
Okay, ma'am.
Okay. So
Yes, ma'am.
overall, you have done a good job. most of the points you had covered up. Still, I do have some feedback. Before that,
Yes.
can you just tell me your own reflection on this task? Anybody would like to happy to give her feedback? I will be happy to listen to them also.
Ma'am, in this station, should we involve the colleague? Like we can say that we involve the consultant and the anesthetic team. If in case this procedure is failed, then might we have to end it up with the cesarean section as well to involve the OT team and everything. This thing is required in the station or not?
No, 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 no. Here the communication with colleague is only midwife and pediatrician. Didn't mention midwife also. She didn't mention pediatrician also. So I will be filling in.
Mm-hmm.
I will be giving at least only borderline in communication with colleague. Along with communicating with me, she has to communicate with the pediatrician and midwife to prepare the equipment trolley of vacuum cup. Okay.
Okay, okay.
Yeah. So see, this is a ST1. You are teaching a ST1.
Mm-hmm.
So less likely here at this point of time, you will be teaching the more complex task. You will be teaching your trainee a simple of the task. Okay,
Mm-hmm.
that means
Okay.
outlet. So that classification also she missed out.
Mm-hmm.
Yes, ma'am.
Yeah, okay.
Okay, so classification, outlet, low forceps, and mid cavity. So it will be a most of the time outlet.
Mm.
So less likely, dear, here. Less likely that you will be expecting a failure or you will be expecting uh, complications. You need to involve senior whenever needed, and you need to offer appropriate interventions whenever needed, but less likely, not needed here. That means you are deviating from the main task. Okay.
Okay. Okay.
One word only you can say whenever this the outcome or the process goes out of means not planned as we planned, it doesn't go in a same line, then we may have to involve our consultant. That one sentence can be said, but not necessary theater, consent, C-section. Okay, all those points are not needed.
Okay, ma'am.
Okay, Dr. Soumya, your own approach, own reflection.
Ma'am, as you said, the time management is
One thing.
no, no, no. Yes, ma'am. Mm,
Mhm.
but I don't know, ma'am. This is the first time I'm presenting, ma'am.
No, dear, you are welcome. You are doing a good job. At least you know the approach how to teach me. You were not forcing or you were not putting everything on me. So you were able to involve me, and I was involved in this whole teaching task. Okay, so that is the one part, one good part about teaching. Okay,
Okay,
that
ma'am.
doesn't mean you have to impart total knowledge. You have to involve me so that I will be comfortable while discussing this teaching aspect. Okay, so that for means that you have done wonderfully. I do not have any issue.
Yes, ma'am.
Anybody will be happy to give her feedback. Then I will go ahead with my feedback, and then we will correct see the answer key. Anybody?
Oh,
Nobody. Okay, so when it comes to feedback, most of the points you had covered up. If I will be giving you domain-wise point, as I said, communication with colleagues. So here all five domains are being tested here. Okay, this is and
okay, ma'am.
to all of you, instrumental delivery is the most common task which is more difficult, although this is one of the common tasks, but means people might or the examiner might find it more complex for us because they expect most of the things to be uh, elaborated or known by a student in part 3 MRCOG. This is a day-to-day skill when we are dealing with OBGYN or obstetrics. So the expectations are pretty high from this instrumental delivery part. Let it be teaching, let it be consent, let it be anything. But this is one task where we need to be aware that they expect so many things from us. Okay, so remember this one point, and that's the reason this is the session. One should be thorough. That is my point. So communication with patient, I will be giving you clear pass because you consented, you explained me, you debriefed me. Okay, so that is basically a communication. Applied clinical knowledge also, I will be giving you a full on pass. Most You are having a very good knowledge about the things what you had said. Patient safety also. Patient safety, I will be giving you borderline. Communicate. We'll see why. Okay, in answer key.
Okay, ma'am.
Uh, Communication with colleague. Information gathering. Okay, information gathering. I will give you full pass because you checked my knowledge. You know, means you asked me whether I have seen any things, what I know about instrument. That one question you missed out. You could have
Yes,
asked
ma'am.
me that one question. Okay, so what means
Okay,
have
ma'am.
you seen is one thing, and what do you know about operative vaginal delivery? That one
Okay,
question. Okay,
ma'am.
and that classification you missed out, dear. So that will come into applied clinical knowledge only, but still the knowledge part you are having very good. I do not have any issue. If you can add that also, very I mean,
Okay, ma'am.
it will be very well. Okay.
Yes, ma'am.
Per se it was a good station done by you. Let's quickly go through it. So whenever you are having props, please take it in hand and try to do it. Okay, try to show them.
Okay,
Hmm?
ma'am.
So introduction, rap building, ruling out bullying, aim of teaching, any particular reason for this teaching session, why I wanted to learn. Okay, you have to ask this question. If I didn't come up with that question. You appreciated with me when I said that I wanted to upgrade my knowledge. Okay, setting agenda, resources, feedback about teaching, which you had covered up in the end. Okay, so see to it if you can cover up here only, because see, if last 10-minute time you didn't get time, at least you know that you had uttered that words. Okay.
Yes, ma'am.
Objective. So in the beginning only you had very nicely divided your station into indication, prerequisite, and procedure. You mentioned in the beginning only application and complications. So that means you had divided very good. Okay. So you have to follow this format. Uh,
Okay, ma'am.
okay. So this
Yes, ma'am.
point also you had covered, completed. Then, what do you mean by vacuum delivery or operative vaginal delivery? Nowadays, it is, who is this unknown user? May I know who is this unknown user? May I know who is this unknown user? Okay. So what do you mean by vacuum delivery or operative vaginal delivery? This one question you can ask. Okay. Operative vaginal or assisted vaginal birth is by forceps or vacuum to aid assist vaginal delivery. There are certain fetal and maternal indications. The incidence is 10 to 15%, 1 in 3 nulligravis. Okay. The skill minimizes C-section at full dilatation. Allow trainee to identify the instrument. You can ask here what means just take this instrument. This is Kiwi forceps, kiwi vacuum cup. Actually that only you can tell here something about this. Okay, main advantage, less means this is extra points what I'm covering. It is not going to affect your passing or failing, but these are the extra points what I'm covering here. Main advantage is less commonly associated with maternal anal sphincter injury and rotational ventouse can less commonly associated with maternal anal sphincter injury. That is main advantage. Ventouse can be used in rotational deliveries with malpositions. Disadvantage is higher failure rate compared to forceps. So indications, as I had mentioned here, fetal and maternal. Maternal exhaustion, medical indications to avoid Valsalva manure. So this is a small part, subpart. So you can, although I had mentioned it in the big diagram, but you can skip it. Okay.
Okay, ma'am.
May I know who is this unknown user who is coming up in frequently? May I know any details from this person? Contraindication. At the same time, when we are seeing indications, always remember contraindication. You mentioned that pelvis needs to be adequate. Okay, so we need to aware that we have ruled out cephalopelvic disc portion. prematurity, that is especially 36 weeks, and less absent consent, hemorrhagic disorder of newborn, infections like HIV. Okay, so these are the contraindications. Called classification: outlet, low, and mid. So what we are doing is most of the time is outlet forceps, and we are teaching them the outlet forceps. Low forceps they need to learn. Okay, if you just need to explain them depending upon the station. We just divide this into mid, low, and outlets. You have to minimize as your sentences. Hmm? Yes or no, dear? Okay,
Yes, ma'am.
so
Yes, ma'am.
yeah, so when the fetal scalp is visible without separating the labia, it is outlet. When the station is between +2 centimeter but not on the perineum, it is low. And when the head is high up or in between 0 to +1 centimeter, it is known as mid.
Uh,
Specifically
okay,
mid
ma'am.
cavity, you do not need to interfere in, means you do not need to go in detail. Just need to mention outlet, low, and mid cavity depending upon the station. You
Okay,
just
ma'am.
need to mention it in one sentence. Now, prerequisite or preparation of the patient. So the basic practical skill has given it very nicely: A, B, C, D up to GH. So if you go systematically, you will not miss out on any point. And I will see to it that they always like this way. So go
Yes,
systematically:
ma'am.
A, B, C, D. So analgesia and assessment, per abdominal and per vaginal assessment. So analgesia and anesthesia, we need to communicate. If the patient is on epidural, continue that or pudendal block. Abdominal examination, basically fetal head should not be more than 1/5 palpable. And per vaginal examination, confirm cervix is fully dilated, station, presenting part. It should be always, means vertex. What we are saying in vacuum delivery, it is vertex. Assess caput molding, and pelvis needs to be adequate. Okay, so this will be suggestive of adequacy of the pelvis. Membranes will be
Okay,
absent.
ma'am.
Yes, you mentioned that membranes will be absent. And determine the station here. You need to determine the station, which is very important. Bladder empty,
Yes, ma'am.
consent, talk to the patient, explain her procedure, pros and cons, inform consultant if it is a low forceps or mid cavity forceps. Outlet forceps, which we are going to apply in the labor ward, need not be involved consultant here. Okay, contraindication: rule out contraindication, whether there is any contraindication to this instrument. Determine station, document in the notes. Exit plan needs to be ready. Neonatologist and episiotomy, neonatologist presence and episiotomy, consider episiotomy. Flexion point: 3 centimeter anterior to the posterior fontanelle. Okay, and here only you are going to apply the cup, center of the cup. Gentle traction and halt, this you had missed out. Patient safety, why I mentioned I will not be
Yes,
giving you
ma'am.
clear pass in patient safety. Halt, when you need to stop, you need to know how many
Yes, ma'am.
pools, how many
Three pulls,
pools.
ma'am.
Yes,
Three
okay.
pulls, ma'am.
Yeah,
Equals.
and then they might ask sequential. That is another question, but I had just made it simple, so I'm not adding sequential instrumentation. They might ask, so a senior opinion needs to be taken into consideration whenever you are thinking of sequential. Okay, so if there are
Okay.
any baby, you can show them a flexion point. So this is flexion points. The center of the cup should be at the flexion point. Okay, now coming to the procedure. So now let's come, Prajakta, let's come, Soumya. We will do it under all aseptic precaution. Respect and ensure dignity and privacy needs to be maintained. That is patient safety. Ensure a
Yes,
lithotomy
ma'am.
position after per abdominal and confirm the per abdominal per vaginal examination here also. Lubricate. Hmm? This is to avoid
Okay.
the trauma.
Injury. Yes,
Introduce
ma'am.
kiwi cup, check suction machine working. Here you can communicate with midwife to keep all equipment trolleys ready. Okay, to keep the
Okay,
machine
ma'am.
working, working equipment all ready. Apply it on the flexion cup. So this kiwi cup will be apply it on the flexion cup. How the center should be, center of the cup will be on the flexion point, and create a suction at the rate of 0.2 kilogram per meter square. Ensure no
Yes,
ream
ma'am.
of cervix will be held in between kiwi and fetal head, which you had mentioned twice or thrice. Gentle traction with a negative pressure of 0.8 kilogram per meter square, I think, not centimeter square. I need to check that.
Okay, ma'am.
Apply traction perpendicular. So here actually what you mentioned the direction of traction. When you mentioned, you were mentioning about the forceps dear. In this case, if you will
Yes,
go
yes, ma'am.
downward forward here and there, your suction cup will be means it will your suction cup will be removed.
Popped on some.
Okay, yeah.
Yes, ma'am.
So it will be always perpendicular in the line in the plane of the cup, using thumb
Okay,
of the
ma'am.
cup, thumb on the cup and finger on the fetal scalp to study it. So you have to mention that
Okay.
study pressure also, so that it will
Okay,
not
ma'am.
come out, it will not pop out. Hmm? Always remember
Yes,
this.
ma'am.
Halt the procedure if no descent with three traction contractions or three pull, or cup pops
Okay,
up
ma'am.
twice. Cup pops up twice.
Okay, ma'am.
Incision episiotomy, assess when the once the baby's head will be started stretching the perineum. Perineal protection at crowding can be protective from third and fourth degree perineal birth trauma. Remove
Okay,
instrument once
ma'am.
the jaw will be visible. After the procedure, take paired blood gases, assess perineal trauma. Baby will be handed over to the baby doctor or a pediatrician. I had mentioned or
Uh,
not mentioned? Not mentioned here,
no, ma'am,
okay?
I didn't mention about that, ma'am.
You've
Yes,
also
ma'am.
not mentioned, even I had not mentioned, but I know that baby, once the baby will be
Okay,
delivered, the
ma'am.
baby will be handed over to the neonatologist. No, we had mentioned in the beginning only that neonatologist will be involved.
Yes, ma'am.
Okay. But once the baby will be delivered, you need to say that the baby will be handed over to the baby doctor.
Yes, ma'am.
Okay.
Okay, ma'am.
Carefully record all findings, indication for assisted vaginal delivery and procedure itself in the notes. And that pro forma, operative vaginal pro forma, you need to fill.
Okay, ma'am.
Okay, so this is another another thing where I am giving. Okay, so this is actually the
Okay, ma'am.
direction of pull. Okay,
Yes, ma'am.
allow trainee to perform and identify any wrongdoing. This is the next important steps you have to discuss. Okay, once this
Okay,
has been
ma'am.
discussed, complication, maternal and fetal complication, which you had mentioned, that PPS third or fourth degree perineal tear, facial mark, hematoma, retinal, means you need to mention few important, at least subgaleal, intracranial hemorrhage. Okay,
Yes, ma'am.
post procedure handing over baby to the pediatrician. Here I mentioned cord blood pH, active management of third stage of labor. Do not miss out. Okay,
Yes, ma'am.
PRPV to assess episiotomy and any third degree or fourth degree perineal tear, estimated blood loss by bladder care, swab needle instrument count, prophylactic antibiotics according to the new guideline, documentation. And
Okay,
so
ma'am.
now you can end the station by asking, how did you find the station? Was it useful? Any feedback for me? Let's do it on the mannequin. Whenever there will be any instrumental delivery, especially kiwi forceps delivery, I will definitely call upon you. Resources are here: basic practical skill, RCOG guideline about assisted vaginal birth.
Okay, ma'am.
Okay, so for easy remembering mnemonics, that is A, B, C, D, E, F, G, H. So this is from the basic practical skill book. So please remember, try to remember this.
Okay, ma'am.
Information gathering, understand the need to first determine the skill of the tutor. What are the skills? Okay, what I know. Means what are my knowledge, expectation of the tutor. So what I wanted to know. Okay, so every time means what are my expectation, you could have asked in the beginning. What, so when you said indication, contraindication, everything you could have asked. So are you interested in knowing all these points, or anything you wanted to miss out? Something
Okay,
like that
ma'am.
you can mention. Means, see, this is a vast topic and you have to concise this topic in that stipulated time. So you
Yes, ma'am.
need to know what are my expectations in today's consult in AIA. So I wanted to perform, I wanted to know whatever along with that classification also. Okay. Communication
Okay,
with
ma'am.
patient and families, appropriate introduce to the patient and partner, explain the role of duty, the nature of interaction with the patient, informed consent for teaching from the patient. Okay. Debrief the
Yes, ma'am.
patient and partner, which you have mentioned.
Yes, ma'am.
Hmm? This means, what does this mean? Obtain informed consent for teaching from the patient. This is one of the important thing. If we are teaching something on the patient, this is here we are
Yes, ma'am.
teaching it on the mannequin. But
Okay, ma'am.
if I am teaching something on a patient, then you have to take a informed consent or a verbal consent from the patient, that will it be okay if I involve my junior and I'll means explain it
Yes.
him the procedure, although something like
Okay,
that.
ma'am.
Okay.
Yes, ma'am.
Communication, I find it out, communication with colleague, when it comes to directly involving me, it was a good communication, because you had mentioned many of points, but few people you need to mention, that is senior help, neonatologist and midwife. Hmm?
Okay,
This
ma'am.
were missed
Yes,
out.
ma'am. Yes, ma'am.
Rest of the points, see, notify midwife and neonatologist of the instrumental delivery. You gave mention most of the points you were mentioned, including the resources also.
Okay, ma'am.
Knowledge of contraindication of Ventouse delivery, is aware of reasoning abandoning the Ventouse cup delivery, consent, discuss pros and cons with patient, maintain patient safety, dignity when teaching practical skill. Okay, so here 3 points you missed out. Understanding
ma'am.
when to continue teaching and when to intervene or halt the teaching session. Undertake appropriate checks to ensure the procedure has been appropriately undertaken. Demonstrate ability to identify risk factor when to involve a consultant. Understanding clinical governance and risk management issues. Suggest adequate training or skill drills. Highlight importance of adherence to the policies and procedure. Extra points. Okay, this is not needed actually. Overall, actually, you have done a good job. I will not have any issue. Okay, anything you wanted to ask from your side?
No, ma'am. Thank you, ma'am. Thank you for the feedback,
Yeah,
ma'am.
thank you, dear. Well done. Keep doing it.
Thank you, ma'am.
Okay, so now